Complications following amputation. So early complications, there can be hemorrhage, infection, flap necrosis and DVT. So if properly the flap is not raised, if the blood supply is not proper, then flap can become necrosed as well. The late complications can be pain and a phantom limb syndrome. Phantom limb syndrome can occur when neuromas form. If the nerves are not sharply cut, neuromas can form there, and these patients can perceive as if the limb is still there and they are still having pain in that limb. So this was briefly about amputation, what has been written in Bailey. For more details, please refer to Dr. Abbas's video as well, where he's discussed amputations in detail. Now, moving on from arterial occlusion, let's move on to the next topic in the arterial system, and that is regarding aneurysms. Aneurysm is a dilatation of the vessel, and the most common type of aneurysm is a fusiform aneurysm. Fusiform is when there is uniform dilatation. When there is uniform dilatation of the vessel, that is a fusiform aneurysm. The most common vessels involved are the vessels of the circle of Willis, and this I've covered in the neurosurgery modules where I've spoken about intracranial aneurysms and subarachnoid hemorrhage. Most common extracranial vessel involved is the infrarenal abdominal aorta. Most common peripheral vessel involved is the popliteal vessel. Most common visceral vessel is splenic artery, and splenic artery aneurysms I've covered in the module on spleen in detail. And the most common vessel involved in mycotic aneurysm is also the aorta. Now, the term mycotic is a misnomer. It does not mean it is a fungal aneurysm. This is bacterial aneurysm, and the organism which is involved is Staph aureus. Right? Pseudoaneurysm formation is commonly seen in the femoral artery. Most commonly seen in the femoral artery, and this is secondary to cannulation or trauma. This can form a pseudoaneurysm. So these were some one-liners which I wanted you to know regarding aneurysms. Let's talk about abdominal aortic aneurysms, something from which questions have been asked a lot of times in the AIIMS exam, and in the future they can be asked in the INI-CET or the SS exam as well. Now, I just told you that infrarenal abdominal aorta is the most common extracranial vessel to be involved with aneurysm formation. The most important risk factor for aneurysm formation is atherosclerosis. So this also you should remember. Atherosclerosis is the most important risk factor. And screening in UK for abdominal aortic aneurysm starts from 65 years of age, and this is done using an ultrasound abdomen. Now, why are we screening for abdominal aortic aneurysms? So the reason why we screen is because it is A, very common in that population set, and B, everyone has figured out there is a critical diameter of the aneurysm. And if that critical diameter is reached, then the chances of rupture of the aneurysm go up exponentially. So what are these critical diameters for all the aneurysms? For abdominal aortic aneurysm, the critical diameter is 5.5 centimeters. That means if an abdominal aortic aneurysm reaches the diameter of 5.5 centimeters, then the chances of rupture go up. And even in asymptomatic patients, then we need to surgically manage this patient. Also, you should remember that the chances of rupture are higher in females. So the critical diameter in females is going to be 5 centimeters. It is 0.5 centimeters less. So this is the critical diameter for abdominal aortic aneurysms. So let me just cover the critical diameters of other aneurysms as well here only, so that you can have all this information in one particular page. Ascending thoracic aortic aneurysms, also the critical diameter is 5.5 centimeters. And it has been seen that if there is more than 0.5 centimeter per year increase in size, that is also considered significant. And in these patients also then surgery is recommended. For descending thoracic aortic aneurysms, the values were changing, but the final value given in the latest Bailey is 6 centimeters. And if there is more than 1 centimeter per year increase in size, then again it is a significant finding in these patients. Marfan's patients are also more predisposed to thoracic aortic aneurysms, and in patients with Marfan syndrome, the critical diameter is 4.5 to 5 centimeters. So these are the values which you should remember regarding critical diameters for various aneurysms. Now, abdominal aortic aneurysms, what are the clinical features? These patients can be asymptomatic and they can just be picked up on routine screening, or these patients can come with abdominal pain. They can come with a mass in the abdomen, and this mass is pulsatile in nature. Sometimes this aneurysm acts as a source of embolus. And this can give rise to blue toe syndrome. So there can be emboli which can get showered from this aneurysm, and they can cause gangrene in the toes, and that is known as blue toe syndrome. These patients can also come with rupture of the aneurysm, and rupture, I will talk about later, is associated with high mortality, and it is usually in the retroperitoneum. So this I'll cover slightly later as well. So these are the clinical features with which patients can present with an abdominal aortic aneurysm. The investigation of choice in a patient with abdominal aortic aneurysm is CT angiography. So CT angiography is the investigation of choice in these patients. Now again, I don't want any confusion. I told you the screening modality is ultrasound abdomen, but the investigation of choice is CT angiography, right? So no confusion at all. CT angio is the investigation of choice, and you can see here, you can see the diameter of the aneurysm in this CT angio and then take a call. The management of abdominal aortic aneurysms, intervention is required. The indications for intervention are in all symptomatic aneurysms, in all symptomatic patients, and in asymptomatic patients, where it is more than 5.5 centimeters in size. These are the patients who require intervention. Now, intervention in abdominal aortic aneurysms can be of two types. You can either have EVAR, which has become the first line of treatment now, or you can have open surgery. EVAR stands for endovascular aneurysm repair, and more than 75 to 80% patients are candidates for EVAR or endovascular aneurysm repair. Now in EVAR, we have to use a graft, and this graft has to get hooked onto the vessel, right? Because we are going by the endovascular route, this graft has to get hooked onto the vessel. So the graft has a body, and the graft has limbs as well, so that this portion will remain in the aorta, and this portion goes in the iliac vessels. This will go in the iliac vessel so that the graft stays in place. Now, what are the places where EVAR is contraindicated? So EVAR is contraindicated when you have difficult iliac access. That is where it is contraindicated. If there is increased angulation, these are the places where doing EVAR is extremely difficult and it is contraindicated. One thing which you need to remember, that if EVAR is done, then these patients have to be kept under lifelong monitoring. And the reason why lifelong monitoring is required is because these patients can develop endoleaks. These grafts can leak. So you can see in the CT angio here, this is what an EVAR looks like. This is what EVAR looks like in the aorta. You can see the hooks there where the graft is in place. This is EVAR. And I told you that endo leaks can occur in these patients. So we have to monitor them lifelong. Type 1 endo leak is Type 1 is proximal or distal to the graft attachment site, right? It is an improper seal which can give rise to type 1 leak, and this is the most common type of leak in thoracic aortic aneurysm repair. This has been asked in the INI SS exam as well. So type 1 is most common for thoracic aortic aneurysm leaks. Type 2 is retrograde flow from the sac through the lumbar vessels. And type 2 is most common in abdominal aortic. So type 2 is retrograde leak from the lumbar vessels, and this is the most common in abdominal aortic aneurysm repair. This has been asked multiple times in the CTVS part of the super specialty exam as well. Type 3 is caused by a defect in the graft due to fabric tear or disconnection. That is type 3. So type 3 is leak from the graft. Type 4 is when there is a porous graft and there is leak. And type 5 is when there is increased tension in the graft, and because of increased tension, there are leaks, endo leaks which develop. So mainly I want you to remember about type 1 and type 2. I want you to know type 1 is most common in thoracic aortic aneurysms repair, and type 2 is most common in abdominal aortic aneurysm repair. So these 2 points I want you to remember for the exam. Now, if we cannot do EVAR, then we carry out open surgery. And in open surgery, we have to carry out a graft repair. We have to carry out a graft repair, and this graft is usually a Dacron graft. This is usually a Dacron graft repair which is done. So, to access the aorta, I first have to carry out certain maneuvers to access the aorta, and then only I can do this grafting. So, we know that the aorta is slightly on the left-hand side, right? Slightly on the left side in the retroperitoneum. So to expose the aorta, we have to carry out a Mattox procedure. Now, what is a Mattox maneuver or Mattox procedure? Mattox procedure is left medial visceral rotation. What does this mean? This means that we are going to mobilize the descending colon. We will mobilize the descending colon medially. And when we mobilize the descending colon medially, that will expose the aorta behind it. So to expose the aorta, we do a Mattox procedure. This Mattox procedure has been asked in the exam. It is left medial visceral rotation, and it is when we mobilize the descending colon medially. Now, you should also know the opposite of Mattox is known as Cattle-Brash, right? The opposite of Mattox is known as Cattle-Brash maneuver, and this is right medial visceral rotation. This is right medial visceral rotation. So here we are going to mobilize the ascending colon medially, and this, when we mobilize the ascending colon medially, this is going to expose the IVC, right? This exposes the IVC. So where will this be used? No, not for IVC aneurysms. This will be used when you have, supposing you have a renal cell carcinoma. Remember, we discussed RCC, and we discussed that RCCs can spread along the renal vein and can go into the IVC as well. So to expose the IVC in such situations, we will carry out a Cattle-Brash maneuver. Another term which I want you to remember, I've covered this in the abdominal modules, is cauterization. Cauterization is when we mobilize the duodenum, that is known as cauterization. So coming back to abdominal aortic aneurysm repair, we will have to carry out a Mattox procedure to expose the aorta. And once we've done that, we will use a graft like this to bridge the aneurysm gap. We will use a graft, a Dacron graft. Okay. So this, you can see, is how we deploy the EVAR graft. We go via the iliac route and then we deploy the graft. Now, you should know about the complications of abdominal aortic aneurysm surgery. Abdominal aortic aneurysm surgery. These have been asked multiple times in the AIIMS exam. The leading cause of death following abdominal aortic aneurysm surgery are cardiovascular causes. This is the most common cause of death following abdominal aortic aneurysm repair. Renal failure can also occur in patients, and an aortoduodenal fistula can occur. So aortoduodenal fistula is the graft which we've done that can get stuck to the duodenum, right? That can get stuck to the duodenum and a fistula can form, and this can present as upper GI hemorrhage. This is a rare cause of upper GI hemorrhage. The patient can also come with melena. So the typical history which you will see in the question is going to be that few years back, abdominal aortic aneurysm repair was done, and now the patient comes with upper GI hemorrhage and melena. What is the most likely cause? It is an aortoduodenal fistula. Okay. Colonic ischemia can occur. This colonic ischemia is commonly seen on the left side of the colon. It is commonly seen in the left side of the colon, and the inferior mesenteric artery is the one which is involved. And patients who develop colonic ischemia in the postoperative period are going to come with bloody stools. They come with bloody stools, and you can diagnose it using colonoscopy, or angiography can tell you about this ischemia. These patients can also develop paraparesis, and this was asked in the AIIMS exam, that why does paraparesis develop in patients following abdominal aortic aneurysm? And this develops because of the involvement of artery of Adam-Keyes. This is the artery of Adam-Keyes which is involved, and this artery of Adam-Keyes supplies the anterior spinal artery. And this can give rise to paraparesis following surgery as well. There can be mortality also following abdominal aortic aneurysm surgery, and mortality following abdominal aortic aneurysm surgery, if it is an elective repair, then it is 2 to 3% is the elective mortality risk. But if it is an emergency repair, would usually be done when there is a rupture. Then in these patients, there is more than 50% mortality rate. This question has also been asked twice in the AIIMS exam. Now, if we talk about a ruptured aortic aneurysm, this rupture will usually occur in the left retroperitoneum. And these patients, the clinical features when a rupture occurs, these patients are going to come with shock. They will come with a pulsatile swelling, shock, and flank pain. So these patients are going to come with shock, a pulsatile swelling, and pain in the abdomen. That is how these patients are going to present. If the patient has stable vitals, we can do a CT angio. You can see this is a CT angio, which is showing us that this is the rupture which has occurred in the left retroperitoneum. And the management of these patients is, again, we have to carry out a Dacron graft repair. A Dacron graft repair has to be done, and when we are operating such patients, I told you there is more than 50% mortality rate in such cases. So this was regarding abdominal aortic aneurysms. Let's now move on to thoraco-abdominal aortic aneurysm. So sometimes these aneurysms can be more extensive, and you can get thoraco-abdominal aortic aneurysms, and this classification is known as the Crawford's classification. This is the Crawford's classification for thoraco-abdominal aortic aneurysms. And what you need to remember for your exam is that type 2 Crawford's is the most extensive thoraco-abdominal aortic aneurysm. Type 2 Crawford is the most extensive thoraco-abdominal aortic aneurysm. Type 1 extends from left subclavian to renal artery. Type 2, I told you, is from left subclavian to aortic bifurcation, and this is the most extensive aneurysm which is present. Type 3 is mid-descending aorta to aortic bifurcation, and type 4 is upper abdominal aorta to infrarenal. Okay, so these are the 4 types, and type 2 is the most extensive. Again, we have to carry out a graft repair in these patients. Moving on to thoracic aortic aneurysms. So thoracic aortic aneurysms can be secondary to atherosclerosis. They can be secondary to atherosclerosis, and they can be seen in Marfan syndrome, like I pointed out earlier as well. They can even be seen in Marfan syndrome. So they can also be seen in Ehlers-Danlos syndrome. Can also be seen in Ehlers-Danlos syndrome. Now, these thoracic aortic aneurysms, the clinical features, how the patient can present, they can either be asymptomatic, so the patients can be asymptomatic, or these patients can come with hoarseness. And this is very important for your exam. This is given in the latest submission. So hoarseness can be due to pressure from, this can be due because of pressure of descending aneurysm, descending thoracic aneurysm on left recurrent laryngeal nerve, can give rise to progressive hoarseness, and this is known as Ortner's syndrome. So this I want you to remember for the exam. This is Ortner's syndrome, which can be because of pressure over the left recurrent laryngeal nerve. These patients can also present with dysphagia. They can come with dysphagia, or they can come with dyspnea as well. Now, if the aneurysm ruptures, then these patients will come with sudden onset dyspnea, and these patients can also develop left-sided pleural effusion. They can develop left-sided pleural effusion. The investigation of choice again in these patients is CT angiography, and management of these patients, we've discussed the critical diameters for ascending and descending thoracic aortic aneurysms. We know the management will be done in all symptomatic patients. In asymptomatic patients, ascending aneurysms 5.5 centimeters is the critical diameter, descending 6 centimeter is the critical diameter, and in Marfan syndrome 4.5 to 5 centimeters is the critical diameter. So all symptomatic patients, and symptomatic can also be those who have aortic valve insufficiency, those who are developing aortic valve insufficiency, which can be picked up on echocardiogram. And these asymptomatic patients, these are the ones who require intervention. Again, the intervention can either be EVAR, or it can be open graft repair, The complications are also similar to what we've discussed for abdominal aortic aneurysm surgery. Now, another very interesting complication here is aortic dissection. So very important for the exam, aortic dissection. Now, what exactly do we mean by dissection? So what do we mean by dissection? So normally we know that this is our externa. This is the media of the vessel, and this is the intima, right? So intima, media, externa. And we know blood is flowing within the intima, which is flowing within the intima. But now if there is a tear in the intima, now blood is going to flow between the intima and the media. And that is dissection. That is called dissection. So what is the thing which triggers the tear? So the most important risk factor which triggers this tear is hypertension. So because of hypertension, the intima splits, and now blood is flowing between the intima and the media. The most common site for aortic dissection is the lateral wall of ascending thoracic aorta. Lateral wall of ascending thoracic aorta is the most common site of aortic dissection. And the clinical features. So chest pain is the most common clinical feature with which these patients present, and this pain radiates to the back. It radiates to the back in the interscapular region. Now, aortic dissection is also more common in males as compared to females, and it is usually seen between the 5th to the 7th decade of life. Now, if this tear extends, if the tear keeps on extending, it can give rise to aortic insufficiency as well. Aortic insufficiency and coronary insufficiency can also be there if the tear extends. aortic and coronary insufficiency can also be there in these patients. Now, these are the clinical features. What are the investigations in these patients with aortic dissection? So the investigation of choice has been asked in the exam. In a stable patient with aortic dissection, the investigation of choice is a CT angiography. And you can see here in the CT angio very clearly that this is the aorta, and you can see the dissection which is occurring. So a parallel lumen is being formed. That is aortic dissection. If the patient is unstable, this has also been asked in the exam. If the patient is unstable, then transesophageal echo is done. Then the investigation of choice is transesophageal echocardiogram. That is the investigation of choice. If you do a chest X-ray in these patients, you can see widening of the mediastinum. There is widening of the mediastinum which is seen, which can be seen in thoracic aneurysms, aortic aneurysms. Otherwise as well, there will be widening of the mediastinum, and there can be left pleural effusion also, which can be seen in these patients. Now, based on the CT angio findings, there are two types of classifications for aortic dissections. You have the DeBakey classification and you have the Stanford's classification. So according to the DeBakey classification, there are three types of aortic dissections. Type 1 is one which involves the ascending plus descending thoracic aorta, and type 1 is the most common. So type 1 involves ascending and descending thoracic aortic dissection is there, and it is the most common type. Type 2 is only ascending thoracic aorta is involved, and this is type 2. Type 1 and type 2 combined are known as Stanford's A. So the other classification is the Stanford's classification, and type 1 and type 2 DeBakey combined are Stanford's A. And type 3 is the one which involves the descending thoracic aorta. And in the latest Sebastian, this has also been further divided into 3A and 3B. This has been divided into 3A and 3B. 3A is when only the descending thoracic aorta is involved. And 3B is when the tear is below the diaphragm. When the tear is below the diaphragm, we call it 3B. And Stanford's B includes DeBakey type 3. So DeBakey type 1 and 2 is Stanford's A, and DeBakey type 3 is Stanford's B. These are the two classifications for aortic dissection which you should know about. Now, like I told you, that hypertension is the one which triggers the tear. But once the tear occurs, there is hypotension, right? Because a parallel lumen has formed and there is hypotension. So the management of these patients, you should know, the management is very important. First, we have to aim towards permissive hypotension. What is permissive hypotension is something which I want you to understand here. This I've also covered in the trauma modules. So like I told you that hypertension is the one which triggers the tear. But once the tear occurs, there's hypotension. Now, when the patient comes with hypotension to the emergency, it is a reflex mechanism to give a lot of fluids. Because there's hypotension, we want the BP to increase. Now, if you give a lot of fluids in this patient, BP will suddenly increase, and when BP increases, the tear will also increase. So a sudden increase in BP in these patients can be counterproductive, which is why BP should be kept, systolic BP should be kept at the lower limit of normal. And that is called permissive hypotension, which is why all patients with aortic dissection, we first give esmolol. Esmolol is a short-acting beta blocker. This has been asked many times in the exam. So first treatment is we give esmolol, which is a short-acting beta blocker, and we will stabilize the patient. If it is a type 1 and 2, DeBakey type 1 and 2, once we've given esmolol, then we have to carry out a graft repair. Then we have to carry out surgery and we have to carry out a graft repair in this patient. Type 3 patients, Type 3 patients are monitored. Type 3 patients are monitored. If progressive symptoms are there, if progressive symptoms are present, then we have to carry out surgery. Otherwise, in these patients, for chronic type 3, conservative management can also be done. But type 1 and type 2, after esmolol, we have to take up the patient for a graft repair. So this covers entirely about aneurysms. I've spoken about abdominal, thoracic and thoraco-abdominal aortic aneurysms. Two more aneurysms which we'll quickly cover. One is popliteal aneurysm. Popliteal, I told you, is the most common peripheral vessel to be involved with aneurysm formation, and 50% popliteal aneurysms are bilateral. Patient will come with a pulsatile swelling behind the knee, and there is loss of contour of the knee behind. There can be pain and distal emboli as well. The investigation of choice in these patients is CT angio, which will tell us about the size of the aneurysm. And the indications for intervention are 2 centimeters is the critical diameter. So asymptomatic aneurysms more than 2 centimeters. And all symptomatic aneurysms, we need to carry out surgery in these patients. Otherwise, we can manage them conservatively. Femoral artery aneurysms are caused by puncture. So if you are puncturing it for cannulating it or puncturing it for some procedure, that can give rise to femoral artery aneurysms. And the critical diameter for femoral artery aneurysms is 3 centimeters. If it is less than 3 centimeters, the treatment is thrombin injection under ultrasound guidance. If it is more than 3 centimeters, then we have to carry out surgical repair in these patients. Now, there are certain brief topics in arterial system which we need to know, and from these topics, invariably one question is usually asked in the MCQ exam. The first one is Raynaud's phenomena. This is a hot favorite of the FMG exam and also the NEET exam. So Raynaud's phenomena is when there is vasospasm, and when there is vasospasm, there are 3 typical changes which take place. So in the first phase, in phase 1 of Raynaud's, what happens that the artery and vein are both in spasm. So when the artery and vein both are in spasm, then the hand is going to become white, or there's going to be pallor, right? You can see here there's pallor, artery and vein both are in spasm. In phase 2, what happens? In phase 2, what happens that the venous spasm is still there, right? So the vein is still in spasm, but the artery dilates. The artery dilates. So what is going to happen? There's going to be deoxygenated blood, which is already here since before, and new oxygenated blood will come and mixed with it, right? So artery relaxes, but vein is in spasm. Vein is still in spasm. So when oxygenated and deoxygenated blood mix, the hand is going to become blue and it is going to be extremely painful, right? So hand is going to become cyanosed and it will be extremely painful. You can see here. And the final phase, phase 3 is when artery and vein both relax. And when artery and vein both relax, then oxygenated blood is going to come in and the hand will become red again. So white, blue, red, that is the sequence of event which is seen in Raynaud's phenomena. Now, there are 2 types of Raynaud's, primary and secondary Raynaud's, and this was also asked in the FMG exam. So primary Raynaud's is more common than secondary Raynaud's, and primary Raynaud's is not associated with collagen vascular diseases, and there can be a family history of Raynaud's phenomena in these patients, okay? Pharmacological treatment is not usually required, and complications are rarely seen in primary Raynaud's, Secondary Raynaud's is commonly seen in patients with collagen vascular diseases like SLE, rheumatoid arthritis. So collagen vascular diseases are usually associated. It is rare as compared to primary Raynaud's, but pharmacological treatment is frequently required and complications can also occur. It has also been seen that Raynaud's phenomena can be seen in patients who use drills, right? Drill workers, so constant vibrating tools if they are using. So that can also give rise to Raynaud's phenomena. So drill workers, vibrating tools, that can also predispose to Raynaud's. Now, the management of Raynaud's, the drug of choice for Raynaud's is calcium channel blockers. This you should know for the exam. This has also been asked. So you should know the sequence of change of color, and you should know the differences between primary and secondary Raynaud's. Another term mentioned in Bailey and Sebastian is acrocyanosis. This is predominantly seen in females. It is painless, right? And it is non-episodic. It is non-episodic unlike Raynaud's. And there is mottled cyanosis followed by paresthesias. So this is a differential diagnosis of Raynaud's phenomena. But I've told you the differences. It is painless and it is non-episodic. Another very interesting condition is subclavian steal syndrome. So subclavian steal syndrome occurs when there is stenosis in the first part, when there is stenosis or block in first part of subclavian artery, And when there is block in the first part of subclavian artery, so flow to that arm will not occur through the subclavian artery. But what happens when the patient starts exercising? When the patient is exercising with subclavian stenosis, there is retrograde flow. There is retrograde flow which occurs from the vertebral vessels, from the vertebral artery. Okay, so this side was the stenosis. Now, when the patient is moving his left arm, where the stenosis was in the subclavian vessel, there is going to be retrograde flow from the vertebral artery. There's going to be retrograde flow preferentially into the left arm. So less blood is going to go into the brain. So when these patients exercise, retrograde flow occurs, and these patients can have syncopal attacks. They can have syncopal attacks. And they can have dizziness. They can have syncopal attacks and dizziness. And this is how patients with subclavian steal syndrome present. The investigation of choice is CT angio. And CT angio will be able to localize the site of block. And the management is angioplasty. The management is angioplasty and stenting in these patients. Carotid artery stenosis is another very common problem which is encountered, and the most common site is bifurcation of the carotid vessels, and the most common cause is that it is secondary to atherosclerosis. Now, clinical features, these patients can be asymptomatic and it can be detected when a Doppler is done for the neck, or they can have transient ischemic attacks. This is the most common presentation, how they present. They can come with transient ischemic attacks. There can be transient ischemic attacks which resolve within 24 hours. Or they can have episodic blindness. This is amaurosis fugax, where they will have momentary blindness and that resolves after some time. They can also have dysphasia, also can be seen in these patients. So again, the investigation of choice here is a duplex scan that will tell us what is the amount of block which is there. The indications for surgery, right? Indication for surgery when there is carotid artery stenosis. There should be 70% or greater stenosis, and there should be ipsilateral amaurosis fugax or monoocular blindness. This is one of the features. Facial paralysis, arm or leg paralysis, hemianopia or dysphasia. These are all clinical features which can be seen with carotid artery stenosis. So if there's a greater than 70% stenosis and any of these findings are there, then we have to intervene and we have to carry out an angioplasty, or we have to do grafting for these patients with carotid artery stenosis. So these indications for surgery have been asked in the INI-CET exam and in the super specialty exam as well. The next condition which we need to discuss is thoracic outlet syndrome. So this is the diagram of thoracic outlet. So you can see here, through the thoracic outlet is what you will get the subclavian vessels. So you have the subclavian vessels coming out. This is the subclavian artery. This is the subclavian vein. And you have the brachial plexus also, which comes out through the thoracic outlet. Now, thoracic outlet syndrome can occur, get blocked, that can give rise to thoracic outlet syndrome, and you can have either arterial blockade. There can either be arterial block or there can be venous symptoms, or the patient can come with neural symptoms or nerve-related symptoms. The causes of block. Why does this block occur? So this can occur because of cervical rib. This can occur because of cervical rib. It can also occur because of poor tone of muscles. So that is why physiotherapy seems to help in these patients. Cervical rib can cause this problem. Arthritis can give rise to this problem. And there can be tumors, which can also predispose to thoracic outlet syndrome. Now, arterial, there will be subclavian artery which will be compressed, subclavian artery which is compressed, and there can be a thrombus which can form here, and there can be embolic phenomena. So emboli can also break off from this thrombus and it can cause distal gangrene, or there can be claudication as well which can occur. In the vein, there can be venous thrombosis. There can be thrombosis of the subclavian vein which can occur, or axillary vein thrombosis can also occur in these patients. And the neural symptoms, there can be brachial plexus. The brachial plexus can get compressed, and that can give rise to symptoms mainly on the ulnar side. So mainly, most commonly, this is on the ulnar distribution. They are seen in the ulnar distribution. So this is how these patients are going to present to us, and the investigation of choice to diagnose thoracic outlet syndrome is a CT angiography. This CT angio will tell us the cause of block and where exactly is the block located. Even a simple X-ray can tell us about cervical rib as well. In thoracic outlet syndrome, there are certain clinical tests which are also done in these patients. And in the last 3 years, lots of times these clinical tests have been asked in the exam. In fact, in one of the INI CET exam, they'd shown a GIF image as well, where they'd shown a particular clinical test and they'd asked you to diagnose which test was it. So I have made a video of all these tests, but quickly let me just tell you the theory, and then I'll show you that video as well so that it becomes clear to you for your exams. Adson's test is when the affected arm is abducted at 30 degrees and at the shoulder. While extending the neck and turning the head towards the same side, we ask the patient to breathe. So you'll see in the video, patient's neck is turned towards the same side, 30-degree abduction and deep breath. And when we do this, we will keep on feeling the pulsation. If we see decreased radial pulsation, then this test is positive. The elevated arm test, so the Roos test, is when they abducted at 90 degrees and they keep on compressing their, opening and closing their fists. And this is going to precipitate pain, then the test is considered as positive. Then upper limb tension test also I've demonstrated in the video as well as the Wright's test also has been demonstrated. So let's see that video of the test and then let's talk about the management of thoracic outlet syndrome. So in this video, I'll demonstrate the elevated arm stress test, or also known popularly as the Roos test. So this is done for thoracic outlet syndrome, and you can see that the patient is asked to first flex the elbows and first abduct the arm at 90 degrees, flex the elbows, and then open and close the palm and make a fist. He does that for 2 or 3 minutes, and if there is thoracic outlet obstruction, then the patient will start feeling pain. There will be pain and fatigue which is going to set in. So in this video, I'm going to demonstrate the Wright's test for thoracic outlet obstruction. To carry out the Wright's test, we first abduct the shoulder of the patient, then we flex the elbow and we do external rotation, right? We ask the patient to clench his fist, and this test would be done in 2 parts. In the first part, when the patient does this stretches the pectoralis minor tendon. And you can see that I'm feeling for the radial pulse. Now, if there is thoracic outlet obstruction, then the radial pulse would be affected and I won't be able to feel the radial pulse. The second step is when I carry out hyperabduction of the shoulder. And when I do hyperabduction of the shoulder, this is going to cause compression of the costoclavicular ligament, and I keep on feeling for the radial pulsation. If the radial pulsation goes away, that means that there is thoracic outlet obstruction. So in this video, I'll be demonstrating the Adson's test for thoracic outlet obstruction. Now, the Adson's test is also one of the provocative tests with which we can know whether there is thoracic outlet obstruction present or not. So in this test, we ask the patient to look towards the side which is affected. This is also called the testing position. Then we ask the patient to take a deep breath inside. Deep breath. And then we ask the patient to hold his breath for 30 seconds. And at the same time, we are feeling for the radial pulsation. The modification is that the arm can be extended by 15 degrees. And a positive test is when we can't feel the radial pulsation. That is known as a positive Adson's test. So the management of thoracic outlet syndrome, if the patient is symptomatic, if there is a cervical rib, that should be resected. Cervical rib needs to be resected. A lot of patients benefit from physiotherapy, especially if it is secondary to arthritis. Physiotherapy is also very beneficial in these patients. If there is an arterial blockade, then we have to do angioplasty in these patients. Angioplasty and stenting needs to be done. And if there is venous thrombosis, then anticoagulants need to be started in patients with thoracic outlet syndrome. Now, another condition which you should know, and the image of this was asked in the NEET exam and the INI-CET exam, this is a cricoid aneurysm. So a cricoid aneurysm is an AV malformation. This is an AV malformation which is seen usually in the region of the scalp or in the extremities. And if it is seen in the region of the scalp, it is commonly associated with the superficial temporal vessels. The superficial temporal vessels are the ones which are commonly involved. And you will see a vascular swelling like this. And this vascular swelling will be pulsatile. It will be a pulsatile swelling. And it is partly compressible as well, right? I've already told you in the hernia module the difference between compressibility and reducibility. Compressibility means when you press it, as soon as you leave it, the swelling will bulge out again, right? Without a counter force also it will bulge out again. So it's a partly compressible swelling. And the clinical features, patients can have cosmetic problems. So cosmetic problems. And because of the pressure, there can be functional problems where there can be pain as well in these patients. And the management of these aneurysms, if the patient is symptomatic, then we have to surgically manage these aneurysms, or embolization can also be carried out in these patients. The next condition is AV fistulae, arteriovenous fistulae. And arteriovenous fistulae, the causes can be traumatic. So they can be traumatic arteriovenous fistulae, like, you can get after liver trauma. I covered in the abdominal trauma module. You can get after renal trauma also, AV fistulae can form. Iatrogenic AV fistulae are the most common, and these are created for dialysis purposes. For renal dialysis, iatrogenic fistulae are created. This is a Semino fistula, which is a radiocephalic fistula. A radiocephalic fistula between the radial artery and the cephalic vein. This is the most common type of arteriovenous fistula. There can be congenital AV fistulae as well. Congenital AV fistulae can be seen in Park-Weber syndrome. I covered Park-Weber syndrome in the varicose vein module. They can be seen in Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome also, you can see congenital AV fistulae. And you can even see them in Sturge-Weber syndrome. Now, the clinical features of arteriovenous fistulae. So the clinical features of arteriovenous fistulae, these patients are going to come with a pulsatile swelling. There is going to be a pulsatile swelling, right? There is a palpable thrill which you can feel over the swelling, and you can auscultate a bruit as well in these patients. Now, if it is a congenital fistula over the limb, in a limb, then it can give rise to hypertrophy of the limb as well. It can give rise to hypertrophy of the limb. And these patients can also develop high output cardiac failure, right? Because it acts as a low resistance channel, there can be high output cardiac failure which can occur in these patients as well. There is one clinical sign which has been asked many times in the exam. This is known as the Nicola-Doni. This is the Nicola-Doni or the Branham sign. So the Nicola-Doni or the Branham sign is when we press the feeding vessel. So when we press the feeding vessel of the AV fistula, what is going to happen? So when you press the feeding vessel, the size of the fistula will reduce. Okay, the size of the fistula is going to reduce. Pulse rate is going to reduce. Thrill and bruit are going to reduce. Thrill and bruit are going to reduce. But the systolic BP is going to increase. So bradycardia and hypertension, right? Brady and hypertension. So systolic BP will increase in these patients and pulse rate is going to decrease. This is the Nicola-Doni or the Branham sign which you should know about. The investigation of choice for AV fistulae is MR angio because MR gives better soft tissue resolution to us. And digital subtraction angiography, DSA's digital subtraction angiography can also be done, but MR angio will be the best answer here. The management of AV fistulae, if symptomatic, if the patient is symptomatic, then the first line of treatment is embolization. The first line of treatment is embolization. But if it is seen, if it is in drug abusers, if you have a fistula, which is an infected fistula, if it is in drug abusers, if there is hypertrophy of the limb, then in these patients, we have to carry out surgical ligation of the fistula. We have to do surgical ligation of the AV fistula. So that is how we manage patients with arteriovenous fistulae. First, we do embolization. Otherwise, in these situations, surgical ligation is carried out. The final thing I want you to know is an arterial ulcer. I've covered this in great detail in the common ulcer module, where I've described of what all points you should note in an arterial ulcer. And if you're given a case of peripheral arterial disease, what are the points which you should look out in the history and examination. So that brings us to the end of this module on arterial disorders. For final year students, short notes regarding this module: Raynaud's phenomena, difference between atherosclerosis versus Berger's. AV fistulae has been asked as a short note in your college exam. Subclavian steal syndrome has also been asked as a short note in the college exams. Okay. Now, before we end this module, let's talk about some MCQs which have been asked in various exams. All our indications for carotid end arterectomy, right? So that is the surgery which is done, carotid end arterectomy. That means you have to remove that thrombus. Carotid end arterectomy is to be done. All of the following are indications except hemianopia is an indication, monoocular blindness is, dysphasia is, persistent hypertension is not an indication, right? So persistent hypertension is not an indication. This question was asked in the INI CET exam. 70-year-old female presents with pain in the thigh during walking. Investigation reveals the following findings. What will be the best surgical treatment? So you can see here, this is the aorta, and the block is in the iliac vessels. Now, if there is an iliac block, I told you for iliac blocks, endovascular procedures work well. So the first line of treatment will be angioplasty with stenting. If angioplasty with stenting fails, then we will carry out a bypass in these patients. But first would be angioplasty and stenting. Which of the following is false regarding investigations for peripheral arterial disease? Duplex scanning is a non-invasive technique. True. On Doppler, normal artery shows biphasic flow. This is false. I told you this is triphasic flow. Digital subtraction angiography is a standard technique. Yes. Computed tomography is not used routinely to diagnose peripheral arterial disease. This is also true. For peripheral arterial disease, we use duplex scanning only. DSA will also be used when we are planning an intervention to know more details regarding the anatomy. That's where we use digital subtraction angiography. So I told you that it is not routinely used. Only if we are planning a revascularization procedure, then computed angiography, CT angio, is going to be used in these patients. We have to match the following. ABPI value less than 0.3 is value for critical limb ischemia. Less than 0.9 is intermittent claudication. 0.9 to 1.3 is normal, and more than 1.3 is seen in chronic kidney disease or calcified vessels. Critical limb ischemia is characterized by all of the following except, so ulceration, rest pain, gangrene, intermittent claudication, no. Critical limb ischemia means already rest pain has started, so no intermittent claudication here. A 30-year-old man with a history of smoking presents with cramping gluteal pain after walking 500 meters. So he walks 500 meters and there's cramping gluteal pain. So gluteal pain, I told you, aortoiliac involvement. Which syndrome did I tell you? Leydig syndrome. This is known as Leydig's syndrome. Male patient presents to the hospital with abdominal pain and is incidentally detected with an abdominal aortic aneurysm. What is the appropriate management for this patient? Okay, so incidentally detected abdominal aortic aneurysm is there. Ultrasound, we monitor the size till it is 5.5 centimeters. That is the treatment. We monitor the size till it is 5.5 centimeters. Which of the following is false regarding abdominal aortic aneurysms? Abdominal aneurysms are more suitable to endovascular repair. This is true. Most abdominal aortic aneurysms rupture in the retroperitoneal space. True. Systolic BP is less than 100, should be maintained less than 100 in rupture. This is permissive hypertension. This is true. And ultrasound is used to diagnose abdominal aortic aneurysm rupture. This is a false statement. This is a false statement. Aortic dissection, true and false. Chest pain radiating to the back is the most common symptom. Hypertension is the most common risk factor. Transesophageal echo is the investigation of choice in unstable patient. Not stable, unstable patient. And first line of treatment is esmolol administration. This is also correct. This was the question which I told you. This is a cricoid aneurysm. I showed you the image as well. This is a cricoid aneurysm. Patient presents with bluish discoloration of the toe, intermittent claudication. What will be the next appropriate investigation? It is going to be a duplex scan, which we've discussed previously. 45-year-old lady presents to the emergency with severe pain in her hand. This was asked in the FMG exam. You can see these are findings of Raynaud's. They have not mentioned any association with collagen vascular diseases. So the answer is going to be primary Raynaud's phenomena. That is the answer, primary Raynaud's phenomena. So these were some questions regarding the arterial system. This is a very, very important module from the point of view of both your college exams and MCQ exams. Thank you.